Okay, let's dive into a really important study that just came out in JAMA Internal Medicine. It's from Grant and colleagues, and it's totally reshaping how we should be thinking about diabetes care in our older patients. And they're tackling one of the toughest nuts to crack in geriatric medicine: how to manage medications safely. And really, the authors just lay it all out there with this one powerful sentence. I mean, think about this. Iatrogenic hypoglycemia has become the leading preventable treatment complication in older adults with type 2 diabetes. Wow. For any of us who see these patients, this isn't just some number on a page. It's what we see in the clinic every single day. It's a huge flashing sign that we need to do something differently. So what is that something? Well, it all comes down to this really dangerous balancing act that we're all familiar with, right? You're trying to weigh those long-term benefits of tight glucose control against the very real, very immediate risks of the treatment itself. And the strategy they're looking at is deprescribing. Now, they're really clear about this. This isn't just, randomly stopping meds. It's a deliberate, systematic process of either tapering or stopping drugs, all with one goal in mind: to cut down on adverse effects. It's an active intervention, not just passive waiting. It's really the opposite of clinical inertia. And the stakes here are they're so high. We're not just talking about the patient feeling shaky from a low. We're talking about a higher risk of cognitive decline, dementia, more falls, lower quality of life, hospitalizations, even death. So for these older folks, the immediate danger of hypoglycemia can absolutely outweigh those more abstract, long-term benefits of getting that A1C down another fraction of a point. So, with that as the backdrop, the researchers at Kaiser Permanente basically asked, okay, how do we fix this? Can we come up with a solution that actually works in the real world, something scalable, to get clinicians to safely deprescribe these high-risk meds like insulin and sulfonylureas? And their solution had two key parts, targeting both the doctor and the patient. First, for the physicians, they got something called academic detailing. Think of it as a quick, focused, evidence-based training session from an endocrinologist. Then, for the patients, they got what the study calls a pre-visit activation tool. And really, it was just a simple one-page handout to get them thinking and ready to talk before they even got to the appointment. Okay, this is where it gets really interesting, because the way they designed this experiment, this clinical trial, is just so smart. It's a great example of a pragmatic trial with some major takeaways for how we all practice. So, who was in the study? It was pretty big. We're talking 211 primary care docs and 450 of their patients. And the patient profile is so important here. They were all 75 or older, had type 2 diabetes, but, and this is key, their A1C was already at or below 8.0%. And they were all on either insulin or a sulfonylurea. This is the exact group we worry about, right? The group where that risk-benefit scale is tipping towards risk. And here's the brilliant part of the design. You have two groups. In both groups, the doctors got the exact same academic detailing. So that's the constant. The only difference, the only thing they changed, was the handout the patient got. The control group got a generic healthy living flyer. The intervention group, they got that special deprescribing handout. It's such a clean design because it lets you see the exact impact of activating the patient. So let's just walk through how this whole patient activation thing worked. The doctor gets trained up on the latest evidence. Then, before the visit, the patient gets this one-page sheet. It explains the pros and cons in simple terms and even gives them a few questions they could ask their doctor. The idea is that when they walk into that exam room, they're both on the same page, ready to have a real, collaborative conversation. So, that's the setup. The big question is, did it actually work? Did this pretty simple change make any difference? Let's get to the results. And this was really the million-dollar question, right? Could a simple, cheap handout for the patient actually change something as ingrained and complex as a doctor's prescribing habits? Well, the answer was a loud and clear yes. Look at these numbers. After 6 months, in the group where only the doctors got trained, the deprescribing rate was 9%. Not bad. But in the group where patients also got the handout, that rate shot up to 15.8%. That's a huge difference. That's clinically meaningful for sure. And this wasn't some fluke. When they adjusted the numbers, the difference was a solid 7.5 percentage points, statistically significant, with a p-value of 0.01. And what's really impressive is that this wasn't just a flash in the pan. The effect was still there when they checked again at the 1-year mark. Okay, but here's the question that every single clinician is going to ask immediately. Was it safe? I mean, it's great that they stopped these meds, but did it cause a spike in high blood sugar? Did it lead to other problems? And the safety data was really reassuring. They looked at things like severe hypos or hospital visits for high blood sugar and found no significant difference between the two groups. And get this, there was also no difference in how many patients saw their A1C drift back up over 8%. So the bottom line is the intervention wasn't just effective, it was also safe. So what's the big takeaway here? What does this mean for how we practice medicine day to day? It really comes down to the incredible power of partnership. You know, the authors themselves said it best. They wrote that these results really highlight how valuable it is to involve both patients and physicians if you want to make real changes to a care plan. It proves that it's not enough to just educate us, the clinicians. You have to bring the patient into the conversation too. I mean, you can boil the whole study down to this. If you just educate the doctor, yeah, you get a modest effect. It helps a little. But when you add that patient activation piece, boom, you nearly double the deprescribing rate. That little one-page handout was a massive force multiplier. It made the doctor's training so much more effective. And if you're looking at this from a health system level, the takeaway is just how incredibly efficient this is. We're talking about a super simple, super cheap intervention that you could roll out everywhere. It empowers patients, it sparks these critical conversations, and at the end of the day, it makes care a whole lot safer. This study really just cracks the door open to so many other possibilities. I mean, think about it. If a simple piece of paper can have this big of an impact on such a complex problem, what's next? What does this tell us about how we can make medicine safer for all of our older patients, not just in diabetes, but across the board?